Hi, I'm Joe Buck. This year alone, 132,000 people will be diagnosed with Parkinson's disease. When patients first receive a diagnosis, they wonder what happens next. The news is life-altering, and treatment options can seem overwhelming. I know firsthand the challenges faced by patients with this disease and their family members because my father, Jack Buck, was diagnosed with Parkinson's in the final years of his life. There's a lot of information out there about Parkinson's disease, and it can be overwhelming to sort through it all. Educating yourself about the latest science and taking advantage of available resources can delay the progression of the disease and greatly improve quality of life. While a diagnosis of Parkinson's disease is without a doubt devastating, there are many ways that daily life can be improved. These videos are designed to inform physicians, therapists, and support facility staff of the latest breakthroughs and treatment options available to their patients. For patients and caregivers, these videos include the latest research on therapies and lifestyle adjustments that enhance the quality of life for people with Parkinson's and other movement disorders. The Greater St. Louis chapter of the American Parkinson Disease Association is expanding its patient services and education programs to better meet the needs of patients and caregivers. These videos are just part of the association's outreach to physicians and patients, especially those in rural communities where services may be hard to find. Experience proves that patients who are educated about what to expect and how to treat Parkinson's disease are able to manage symptoms and enjoy a better quality of life. There are many medication options, treatments, and lifestyle modifications that can help with that. Now let's begin to learn more and broaden our knowledge about Parkinson's disease now and in the future.
Both my wife and I were very surprised by the diagnosis.
I had no idea about the scope of the changes I'd have to make.
She really recognized the sign before we did.
I found myself a lot of times just holding my breath, hoping that he was going to make it down the flight of stairs okay.
I feel fortunate, and I'm going to, just try as best I can to live a normal life.
And there's many things to be thankful for in my life. This is just one small obstacle, and I want to enjoy my life and be there for my family as long as possible and do whatever I can.
Parkinson's disease is a brain disorder characterized by the slow degeneration of nerve cells or neurons in a part of the brain that controls movement called the substantia nigra.
Parkinson's disease is a brain disease, a neurologic disorder that's progressive, affects older people, and their risk increases as they get older. It affects, on average, people about age 60 is the average age of onset. It causes problems with movement, including shaking, slowness, stiffness, trouble walking, trouble with speech, trouble with swallowing. But in addition to the more obvious motor findings, there are also a whole host of non-motor manifestations as well, including even things like difficulty with constipation, control of blood pressure, a wide variety of things, including thinking as well. So it's a progressive disorder. There are various causes of it, and right now it's a disorder that we can treat the symptoms of, but we don't yet have a cure.
Symptoms are classified as motor and non-motor. Not everyone has the same symptoms or rate of progression. When making a diagnosis, physicians look for 4 primary or cardinal symptoms: tremor at rest, slowness of movement called bradykinesia, stiffness of muscles, balance problems, and a stooped posture.
The shaking that we have with Parkinson's is what we call a shaking at rest or a tremor at rest. Usually affects one side of the body more than the other, as does the slowness and stiffness. Although it may start on one side, it typically spreads to both sides.
Other motor symptoms include shuffled steps and a decreased arm swing.
There are difficulties with walking, with slow shuffling gait. People can even have a sudden cessation of gait where they freeze, and that freezing may occur when first standing or when turning or going through doorways or even with crowds. And those kinds of difficulties can lead to falling.
Some secondary symptoms of Parkinson's are a lack of facial expression, speech that becomes slow or slurred, small, cramped handwriting, and constipation or urinary incontinence. And there are some non-motor symptoms that may occur in people with Parkinson's, including mood and sleep disorders, problems swallowing, drooling, low blood pressure, pain, and cognitive or thinking problems.
Troubles with the cognitive problem that can occur with Parkinson's are the kinds of difficulties that occur with when people try to multitask, for example. Figuring out how to use the remote control would be a common question that I'll ask and a good test. Or are they able to do the bills? These are clues that there may be difficulties with cognitive processing that's developing. And people with Parkinson's are at higher risk. And that risk is variable depending upon the study, but maybe anywhere from 30 to 60 or even 80% of people with Parkinson's may eventually have that kind of trouble.
Parkinson's is truly an individualized disease. Symptoms and the rate at which the disease progresses varies from person to person.
It's a disease that is extremely diverse in its the way the symptoms come out and the way the disease progresses. I think one of the most frustrating parts of the disease for the patients and probably the doctors is the fact that we don't have a crystal ball. I can't tell them how quickly the disease is going to progress. I can't tell them, where they're going to be in 5 or 10 years. That we just don't know.
What is known, however, is that certain medications reduce the symptoms of Parkinson's disease, enabling many people to live full, productive lives. To understand how the medication works, it's helpful to understand what goes on in the brain of a person with Parkinson's.
It's a group of disorders in the brain that affects a very specific part of the brain, and that would be called the substantia nigra, which is in the upper part of the brainstem called the midbrain. And there's loss of nerve cells there, and there's deposition of an abnormal protein we call alpha-synuclein. And those nerve cells in the substantia nigra project or send connections to an area higher in the brain we call the striatum. And those connections communicate with the nerves in the striatum by releasing a chemical messenger. That chemical messenger is dopamine. And so in Parkinson's disease, we see a loss of the nerve cells in the substantia nigra and a reduction of dopamine in the striatum. And in the remaining nerve cells, there's abnormal deposition of alpha-synuclein in little inclusions we call Lewy bodies.
Because symptoms of Parkinson's disease are caused by a reduction of the brain chemical dopamine, medications such as levodopa are used to restore dopamine to the brain. This may alleviate symptoms for many years. Other medications used to treat Parkinson's symptoms are called dopamine agonists. For more on medications, see Chapter 4 of this video. For people living with Parkinson's disease and their families, progress is always too slow. But there are reasons to be optimistic. It is anticipated that today's many scientific advances will translate into benefits.
We really do make a difference for people. We make symptoms better.
We're making headway on trying to find treatments that can not only slow the progression of the disease, but potentially reverse the damage in the brain.
There are lots of reasons to be hopeful, and there are lots of great areas of research that are being developed.
Today is so much more hopeful than 15 or 20 years ago, even 5 years ago.
Today, over 4 million people around the world live with Parkinson's disease. It's predicted that number will increase to 8.7 million people worldwide by the year 2030. In the United States alone, an estimated 1 million to 1.5 million people live with the disease, with 132,000 new cases diagnosed each year. These numbers don't include the thousands of cases that go undetected. Researchers at Washington University conducted a study using Medicare data to pinpoint who is most likely to be diagnosed with Parkinson's disease. Age, gender, and where you live are all factors associated with developing Parkinson's.
As you age, your risk of developing Parkinson's disease is greater. it's 1 to 2% overall above about 60, but the risk as you get into your 80s is substantially higher. Men have a substantially greater risk of Parkinson's than women. Whites have a much greater risk than blacks or Asians. One of the things that we have discovered in our work here at Washington University is that where you live seems to make a difference, and it's actually a fairly strong risk factor for Parkinson's disease. So we found that certain areas in the Midwest and Northeast have a much higher rate of Parkinson's than areas in the West and South. We believe that represents an important risk factor for Parkinson's disease, but how that's mediated is less clear.
The exact causes of Parkinson's disease are unknown, but research points to a combination of genetic and environmental factors. The nation's top researchers are investigating what might contribute to a diagnosis. It is known that a very small number of patients have a gene that causes the disease.
About 5% of Parkinson's disease cases are what we call monogenetic, and that means that there's a single gene that accounts for the disease. It's sufficient to cause the disease.
For most patients, the cause is unknown. Pesticides and heavy metals are two factors being studied as possible environmental triggers.
It is still a puzzle. There aren't many pesticides being sprayed in large quantities in urban areas, but there are other kinds of pollutants. Pollution from factories, pollution from cars, pollution from chemicals being put into the air, pollution from dust in urban areas, and all of these things might increase your risk of Parkinson's disease in urban areas.
We have done some studies that show that living in an area where there are industries that put out heavy metals into the environment, in particular manganese, does seem to increase the risk of Parkinson's disease.
Researchers hope that identifying patterns will allow for early detection, making it possible to slow or even stop the progression of symptoms. Most people with Parkinson's have some non-motor symptoms long before they are diagnosed. If studies can prove a correlation, it may be possible to treat before motor symptoms occur.
There's some very compelling evidence now that Parkinson's disease starts outside of the brain, potentially in the gastrointestinal system. People with Parkinson's disease have constipation decades before they develop the movement symptoms of Parkinson's disease. There may be early changes in the spinal cord and even outside of the motor parts of the brain. There's a syndrome called REM sleep behavior disorder, and this is a situation where people act out their dreams at night and hit their spouses, and the brain doesn't shut down during what we call REM sleep. This is our dreaming state of sleep. And a very high percent of people who have that particular problem called REM sleep behavior disorder go on to develop Parkinson's disease. And that can be decades before the disease as well.
Often the diagnosis of Parkinson's is first made by an internist or family physician. Many people seek an additional opinion from a neurologist with experience and specific training in the assessment and treatment of Parkinson's disease. This person is referred to as a movement disorder specialist.
It's reasonable to see a neurologist early on in your Parkinson's disease, at least once, just to make sure that there aren't any other conditions that need to be addressed, or there aren't any other conditions that mimic Parkinson's disease but are not.
Going to a neurologist is very helpful and can improve the quality of life and prolong an individual's life. If there's additional difficulties, then seeing a movement disorder specialist is valuable.
Some people with Parkinson's may not have a specialist in their area. In such cases, it may be worthwhile to travel once or twice a year to see a specialist who can work with a local general neurologist to provide the best care possible. As awareness of Parkinson's disease increases, more research is being conducted into causes and ways to improve treatment. While there is no cure for Parkinson's disease yet, a movement disorder specialist or a family practitioner or neurologist in consultation with a movement disorder specialist can manage and minimize the symptoms, improving the quality of life for many years to come.
course of Parkinson's is so different in so many different people.
I would say I probably went through a period of depression.
He's behaving that way because of his fear of what is happening for him.
It can be draining for, those around the person with Parkinson's.
In addition to the motor symptoms most associated with Parkinson's disease, many people experience a number of cognitive and psychological symptoms. For example, depression occurs in approximately 40% of people with Parkinson's. Some people with depression also experience feelings of anxiety or panic. It's important to bring these symptoms to the attention of a medical professional.
In the course of taking care of someone's movement problems, we don't always inquire or manage the depressive symptoms adequately. Treating depression is one of the most important things that can be done. And what's surprising is that, for over 20 years, there's been really clear evidence that depression is very common in people with Parkinson's. Many of the parts of your brain that allow you to enjoy things or that motivate you to get up and do something every day relate to the dopamine system. And in Parkinson's, we know that that's been eaten away at and you don't have enough dopamine.
So we think it may in fact be part of the illness. Similar pathways in the brain may be involved. So in some cases, just treating their Parkinson's helps their depressive symptoms. In other cases, their depression is really the more severe problem. It's adding an extra stress, making the Parkinsonism worse, and we help their Parkinson's by treating their depression.
Changes in mood are related to reduced levels of serotonin, stress from lifestyle changes, and side effects of medication. Some of the changes most often observed include fatigue or lack of energy. This is a very common symptom of the disease as the body works hard to accomplish the simplest of tasks. An inability to experience pleasure from activities previously enjoyed, and apathy or passivity, meaning a lack of motivation or initiative. It's important to distinguish between apathy and depression.
Frequently misinterpreted by a significant other as depression because they have a mask-like faces with Parkinson's, so that means less facial expression, seem to not want to go out and do things. But if one actually talks to the person, their mood may not be reduced at all, but they just have this lack of motivation.
In addition to depression, many people with Parkinson's suffer from anxiety.
Anxiety is actually even more common in Parkinson's than depression is. About a third of patients with Parkinson's disease have anxiety that's bad enough to interfere with their life or require treatment. And with the anxiety, it's even more clear that that relates to the disease itself. If you look back 20 years before the diagnosis of Parkinson's disease, before people ever had a clue they were going to have Parkinson's, it's clear that they have many times the risk of having social phobia, panic disorder, some of the other anxiety problems.
Nearly all people with Parkinson's disease will experience some cognitive changes. Those who develop dementia may experience slowed thought processes, memory problems, difficulty with concentrating, word-finding difficulty, poor judgment, or apathy. As Parkinson's disease progresses, some patients may have problems controlling impulses or may experience delusions or hallucinations.
When somebody's wide awake and they see somebody at the dinner table who's not there, or hear somebody carrying on a conversation with them and then realize that nobody's actually there, that's a concern. To me, what it means is, there's something wrong with your brain at that moment. It could be because of the medicine you're taking or whatever, but something's not going right. In fact, there was a research study a little while ago that said that one of the most common reasons for people with Parkinson's disease to be transferred to a nursing home from a family home was because of hallucinations.
But then there's another group of what we call psychotic symptoms that may occur, and those are abnormal thinking patterns, like suspicious thinking, worried the spouse is trying to poison them, or there are people in the basement, they're going to get them, and they run out in the night from their house naked, screaming in the street, or call the police. That happens.
There's a complication of treatment for Parkinson's that's usually called impulse control disorders. And this refers to things that people might do anyway, like gambling, sexual indiscretions, spending money you don't have. It's very, very clear that people who take the newer medications for treatment of Parkinson's disease, dopamine agonists, are at a fairly high risk of developing these impulse control disorders for the first time in their life, let's say at age 60. Basically, the parts of your brain that normally keep you from doing stupid things kind of get impaired sometimes. And it's only maybe 10 or 20% of patients with Parkinson's disease who are taking one of the dopamine agonists. It can happen with the L-DOPA, but it's less common. Usually you can relate the development of that impulse control disorder to the start of a particular medicine or a month when you raise the dose. And in that case, cutting back makes good sense. The problem is you raise the dose for a reason. And so trying to balance out helping you move and think and talk appropriately with avoiding side effects can be difficult.
While the cognitive and psychosocial aspects of Parkinson's disease present difficulties for families and caregivers, much can be done to alleviate the symptoms. Communication with your doctor is important. Parkinson's is a very individualized disease, and each person who lives with it requires a unique treatment plan. The goal of treatment is to make this disease as insignificant as possible.
If you know that there's something not right, you bring it to the attention of your doctor. Serious research and serious attention have gone in, just in the last 10 years, have gone into symptoms like hallucinations, the impulse control disorders, depression and anxiety. It wouldn't be at all surprising to find out that, 10 or 15 years from now, people are doing a lot better than they are now.
Because each person with Parkinson's experiences the disease differently, physicians can't accurately predict its course for any individual. Instead, the focus is on reducing symptoms, preventing complications, and improving the quality of life.
There is no proven medicine to slow the progression of Parkinson's disease. What we can do is we treat the symptoms of Parkinson's. So if the symptoms are causing functional impairment, embarrassment because somebody's embarrassed about their shaking and won't go out and stays in the house, that's impairing their lifestyle, that person should have treatment for their symptoms. What medicine should we start? The most effective, potent medicine, without any question, is what we call levodopa. Levodopa is the immediate precursor of dopamine. That means if somebody takes levodopa, puts it in their mouth, it gets in their bloodstream, crosses into the brain, and gets converted in the brain to dopamine, it helps to replace the missing dopamine. Very straightforward, very effective, especially in people with mild Parkinson's.
While effective for as long as 10 years in alleviating the symptoms of Parkinson's disease, levodopa causes side effects, including nausea, decreased appetite, vomiting, rapid heart rate, and lowered blood pressure, which can lead to dizziness or falls. Another class of drugs is called dopamine agonists, which stimulate the brain's dopamine receptors.
They have an advantage because they last a little longer in the blood and in the brain effect. That's an advantage. They're all less potent than levodopa. They also all have more side effects. So if somebody already has trouble with a drop in blood pressure, when they stand up, the dopamine agonists will make that worse. If they already have trouble with concentration and memory, dopamine agonists will tend to make that worse. In addition, dopamine agonists can cause excessive daytime sleepiness more commonly than L-DOPA does. So that's another reason for one versus the other. And finally, the dopamine agonists may have a condition that's really unique to them, and that's what we call impulse control disorders. So people start taking these medicines and may, now most don't, but some do, develop problems like sudden shopaholic, sudden unusual sexual appetites or urges, gambling disorder. I use levodopa. I use the lowest dose possible, but I use the lowest dose that's effective, but not lower than that.
In addition to levodopa and dopamine agonists, other classes of drugs may be prescribed, such as COMT inhibitors and MAOB inhibitors. Each type has a different action. People often take Parkinson's medications in unique combinations. It's critical to take medications on time as prescribed by a physician. For some patients, even a slight fluctuation in schedule can cause symptoms to worsen, diminishing the quality of life. When symptoms become worse, caregivers may think the patient needs more medication, leading to unneeded increases in dosage.
As the disease progresses, the duration of response to individual doses can be shorter and shorter. In some people that may be 3 or 4 hours, in others it may be 60 minutes. And so then we find that if they can't tolerate a higher dose, in some people we just increase the dose to increase the duration of response, but if they have side effects from too high of a dose at one time, then we have to make the doses shorter or closer together. There it can be very critical to take the medicine precisely as directed.
Medications used to treat other conditions can often be harmful to people with Parkinson's and need to be avoided or used with extreme caution. Medications on this list all have dopamine antagonistic properties. Simply put, they cause a further decrease in dopamine, the brain chemical that is lacking in people with Parkinson's. People with Parkinson's and their families need to be careful to avoid these medications. More information about this can be found on the website of the Greater St. Louis chapter of the American Parkinson's Disease Association. If medications become less effective, what can be done to alleviate symptoms? For a small subset of people who no longer respond well to medication, surgery may be an option. In the early 1990s, a procedure called deep brain stimulation was developed. The treatment uses a device similar to a cardiac pacemaker to deliver carefully controlled electrical stimulation to targeted areas of the brain. As a result, many people achieve greater control over body movements. After surgery, the level of stimulation can be adjusted non-invasively, maximizing symptom control and minimizing side effects.
It takes about 4 to 6 months to adjust the stimulator. In these 4 to 6 months, we'll have to see the patients every 4 to 6 weeks to make fine-tuning of their DBS therapy. After 6 months, most patients are reasonably well programmed, and they're up and around and doing reasonably well, so we get to see them every 3 to 6 months, depending on how well they're doing.
Neither medications nor surgery are cures for Parkinson's disease. Moreover, not every person with Parkinson's is a good candidate for surgery. But the combination of medication and deep brain stimulation can manage symptoms for many years.
Medication will improve the quality of life of a Parkinson patient for the first 5 to 7 years. They'll do extremely well during that time. Between 5 and 10 years, they'll have a little bit more motor fluctuation, and they're probably going to have to take more medications. They're probably also going to have more of the dyskinesia, the dancing, wiggly-like movements that's induced by medication. By 5 to 15 years, the deep brain stimulation is very useful at helping out with controlling the motor fluctuation as well as the dyskinesias. That will cover them for another 10 years or so.
You can make a choice to go and exercise and do for yourself and know that you're helping to make a difference and helping to manage your disease.
So I think it's very important to stay physically fit and mentally fit.
I think just if he can speak louder, he can be more of who he was.
It's possible to have power over Parkinson's, and that comes sometimes from what we can do with rehabilitation.
Many symptoms of Parkinson's disease can be managed with medications prescribed by a movement disorder specialist, a neurologist, or a primary care physician. In addition, therapy, exercise programs, and lifestyle modifications have a positive impact on the quality of life of people with Parkinson's. Physical therapy and exercise help a person with Parkinson's maintain a greater range of motion, reduce pain, and improve balance.
As the disease progresses, people become more rigid, their posture changes, and so they're very susceptible to getting stiffness and tightness in their muscles and joints, which can limit their mobility, contribute to pain, and limited function.
People with Parkinson's are at a greater risk of falling. A physical therapist can assess and improve balance, which can greatly impact the daily life of a person with the disease.
There are a number of different studies that suggest that physical therapy can definitely improve individuals' balance. both over a very short course of physical therapy and over some studies that have looked at up to 6 months of exercise.
It's not good enough for a therapist to say, have you had any falls? Because the patient may say, no, I haven't had any falls, but they're wall walking or they're losing their balance and they're catching themselves every few steps. So you can get fooled by not asking about, well, how many near misses do you have where you lose your balance but catch yourself? I typically will do a battery of tests or outcome measures of someone's balance so that I can clearly document where they are on a continuum with regard to their fall risk. And it's very helpful to be able to show a patient a number on a particular scale to give them information to know how good or how poor their balance is.
We also see that people who've had the disease for 5 years or longer sometimes will develop a phenomenon called freezing of gait, which they will describe as if in the middle of walking they suddenly cannot move and they feel as if their feet are glued to the floor.
The conditions that most commonly contribute to freezing are turning. It can be a turn in a particular direction. The brain's perception of the individual being in a small or crowded space tends to trigger a freezing event. So, for example, when someone walks through a doorway and the brain perceives the patient walking through a smaller, more narrow space, that will trigger a freeze.
A physical therapist who specializes in movement disorders can teach techniques to break a freeze by using visual or auditory cues.
So, for example, you might assess a patient and ask them to count out loud at a particular beat, either out loud or in their head, or have a song in their head, but something in their brain or out loud that is at a set rhythm or cadence. Some individuals may carry, I've had patients carry laser pointers, and when they freeze or when they're about to freeze, they point the laser as a visual target to step on or step over. They also make a brand of canes and walkers called U-step walkers and canes that have a laser pointer built into the device. When you press a button, it emits a line on the floor.
Within the home, some simple modifications can prevent falls, keep a person with Parkinson's safe, and support independent living.
The occupational therapist will usually ask the person what he or she is having difficulties with, and then they can observe the person performing those activities in their home environment. And so usually we start off by just having a structured interview that involves asking questions to the person and their caregiver or their family member about things that have become difficult for them, or things that they need or want to do but maybe can't do anymore, or feel like it's taking more effort than it should, or time. The goal is to allow the person to participate in the activities that he or she finds meaningful.
Low-cost adaptations may be as simple as removing hazards like clutter and throw rugs, or installing grab bars and enhanced lighting. More extensive adaptations may include installing ramps, special shower benches or seats, or higher toilets. Wider showers, hallways, and doorways provide wheelchair access. As the disease progresses, people with Parkinson's often find adaptive equipment to be useful, including reachers, built-up utensils, and sock aids.
You know, there are so many different options and possibilities for people to self-manage their own disease and their own symptoms and take control of their daily lives.
Since falls can happen, a physical therapist can teach a person with Parkinson's how to get up safely.
So whichever leg you prefer, you'll bring that one up.
And if a caregiver needs to help the person who has fallen, there is a safe way to do that. To see a full demonstration of these techniques, go to the bonus features of this video. Exercise of any type benefits Parkinson's patients, but because having Parkinson's disease can be isolating, there seems to be an added benefit from group exercise.
Over the past 5 years, we've done a number of studies focusing on the benefits of dance for people with Parkinson's. And we've compared tango dancing specifically to a number of different exercise approaches, including other types of dance, Tai Chi, traditional exercise, and even no exercise. And all of our studies have consistently shown that participating in tango can help people with Parkinson's disease to improve their walking, to improve their balance, and also to enhance their quality of life. We think it's a real change that's taking place. It's not that they're now taking more medicine than they were a year ago, or that the medicine is somehow more effective, but that we're actually modifying the progression of motor symptoms associated with the disease through participation in exercise.
One of the earliest symptoms of Parkinson's disease is a change in the voice. A person's voice may become soft and their speech may slow or become slurred. The person with Parkinson's usually does not recognize the changes right away. It's most often the caregiver who notices first.
I have not myself noticed much of a change. Now, I'm probably the last to know because I'm not the one that's listening. You know, ask my wife and you'll hear a different story.
It's only been in the last couple of years that I've noticed a problem because I've had a harder time hearing him and to distinguish what he says. It's not that he's mumbling exactly, it just seems as though his enunciation isn't quite as distinct as it used to be.
I'm pretty sure that there is a change. I also hear it when I'm talking on the phone. You know, on the other end of the line they say they can't hear me. So, you know, that's another bit of evidence that it's there, but I just don't recognize it.
Bob's Parkinson's disease has progressed slowly, but the changes in his speech are noticeable. Dr. Cynthia Fox led Bob in a session of Lee Silverman voice treatment.
All right, so we're going to start with the exercises. I just want you to watch me and do what I do. It was developed about 20 years ago. Mrs. Lee Silverman actually was a woman with Parkinson's disease. And when Dr. Lorraine Ramig met her family, they really had the expressed wish of, if only we can hear and understand her. So that's sort of the origin of the name. The protocol itself is an intensive speech treatment protocol. Some of the unique features of it is that it really focuses on training healthy vocal loudness.
Please turn down the TV.
Nice. So many patients with Parkinson's disease get very soft, mumbled speech, and we target on just one aspect of that, improving vocal loudness. And what we see is that by targeting just loudness, we get improvements in things like articulation, so the clarity of speech, as well as some improvements in things such as facial expression.
People with Parkinson's often feel as if they are shouting when actually speaking quite softly.
It takes some effort to
put that volume out?
Put that volume out, yes.
It sounds good. The results can be quite dramatic.
The rookie returned the punt for a touchdown.
What we recognize today is that even with optimal pharmacological or surgical medication, speech problems persist. And what we can tap into with rehabilitation is a lot of capabilities that they have that they can pull out themselves, and that gives them a lot of power. You're seeing somebody who has confidence in communication, which is such a huge piece of what we do in everyday life, our self-worth.
LSVT is provided by a trained clinician in one-on-one sessions. For more about the Lee Silverman Voice Treatment Program, go to the bonus features of this video. Exercise and therapy can give people with Parkinson's disease a greater sense of control over their lives. These therapies, combined with home modifications, can keep people with Parkinson's independent for a longer period of time and allow them to live full lives over the course of the disease.